Assalamualaikum and a very good morning. Thank you so very much to everyone who is actually at the moment in the webinar session this morning. Today is Wednesday on the 23rd of February 2022. So we're nearly to the end of February. My name is Dr. Azriyanti binti Anuar Zaini. So I'll be the first session moderator for today. Thank you to all for being able to join us this morning. I understand that the session today is actually open to all UM staff, students, as well as the PPUM family members, as well as the public domain as well, if they are interested and keen to join via the FB as well as IG session. Right, so today I'm not going to take much of the time to introduce everyone today. We've got two interesting sessions. So the first session, I'll be leading the session today, this morning, under the Pediatric Department of Medicine. So we will be having two speakers. And two of them are my fellow in training, but actually one of them has just recently passed. So I'll be introducing her in a while. So the aim for today is actually to just a quick review from the Department of Paediatrics. What we will be doing is actually to introduce you and give you a little bit of awareness, as well as a little bit of an update on central precocious puberty in children. So without further ado, I would like to introduce our first speaker for the morning. I've got Dr. Meenal Mavinkurve. Meenal, you can open up your video now. So she is currently my trainee, our trainee, myself and Professor Yazid trainee in UMMC. She is also the consultant pediatrician and lecturer in the International Medical University in Seremban. So Dr. Meenal will be giving us a short overview on three cases that she'll be sharing today in terms of managing as well as presentation of children with central precocious puberty. The floor is yours, Meenal. Go ahead.
Okay, thank you, Prof. Yanti. Okay, so a very good morning to everybody. So I will be speaking for the first session, and I'll be talking about three cases and what lessons can be learned from cases of central precocious puberty in children. So this is what I propose to cover over the next couple of minutes or so. I'll touch on the case studies, what are the lessons learned from these cases, and then the red flags, and then finally the road to referral. So case number one is that of a 6-year, 4-month-old boy who was referred to us at a fairly late stage of puberty. He had already developed pubic hair and facial hair with acne at the age of 5 years and 5 months. He had also developed an adult male voice, which is quite a late stage in his puberty, actually. And this had happened at the age of 5 years and 7 months. He'd developed an increase in his height velocity, which usually happens in the later stages of puberty. And he also had an adult body odor. Now, symptoms that are important to elicit in such a case is whether or not he has any central nervous system signs or symptoms, which he did not, whether he has any visual field defects, which he also did not. And he didn't have any symptoms that were consistent with central diabetes insipidus. His initial history wasn't really that contributory to his presentation. He had a little bit of isolated speech delay. There were no pubertal problems that were running in this family either. So on physical examination, you can see that he's actually quite a tall boy. And if you compare it to his mid-parental height, which is indicated there as an MPH, you can see that he's really quite tall for his parental average. On his physical examination, which was really quite remarkable, he had a very muscular build. He also had facial acne and a mustache and an adult male voice, which was quite amusing, coming from a 6-year-old boy. He didn't have any neurological deficits, and he had normal visual fields as well. And you can see that from his pubertal Tanner staging that he's quite advanced in his puberty, Tanner stage 4 in terms of pubic hair, and his testicular volumes were actually adult size with testicular volumes of 20 milliliters bilaterally. So this is his growth chart. You can see that he's quite tall compared to the population average, as well as his parental average, his mid-parental height. And that triangle signifies his bone age, which is significantly advanced. And what that essentially shows us is the fact that this process is not something that happened overnight. It is a process that has been ongoing with the release of testosterone that converts to estrogen and then ultimately advances your bone age quite significantly. So knowing that puberty commences, or central or true puberty, starts with from your pituitary gland, our next port of call was to actually evaluate the remainder of his pituitary function. You can see that his thyroid axis is adequate. He has an adequate free T4 level to proceed for surgery if required, as was his adrenal axis, which is a good cortisol level at 8 a.m. in the morning. His hypothalamic pituitary gonadal axis is active, as indicated by an elevated basal LH and a high testosterone level. And this would be consistent with his presentation of central precocious puberty. And finally, his thirst axis was intact, and he does not have any features of either compensated or central diabetes insipidus. You can see that his serum tumor markers are fairly reassuring as well. This is his bone age. We evaluate each of the individual bones, and we got a bone age of 13.2 years, which, as I mentioned earlier, is really quite advanced for this boy. So his MRI, this was done at an outside hospital, showed that he had a multicystic hypothalamic lesion, which was above the pituitary stalk. The pituitary gland itself and the stalk were not involved. There was no enlargement of either of those, nor was there any enhancing. And his posterior pituitary bright spot is visible, which would be consistent with his clinical presentation in terms of the absence of central diabetes insipidus. So he went on to have a craniotomy and tumor debulking, and this was uneventful. Luckily, he had a good postoperative course. He did not develop diabetes insipidus. He also had normal postoperative pituitary hormone testing. And in terms of his central precocious puberty, we commenced him on a GnRH analog, and his HPE analysis revealed that he had a pilocytic astrocytoma. So what can we learn from this first case? Well, first of all, I think if there's any take-home message from this case is that we all have to be aware, or beware, of boys with central precocious puberty. Any boy that presents with early puberty, which is enlargement of the testes below the age of 9, is not idiopathic. It is rarely idiopathic, in fact. And we have to look hard for an intracranial problem, and obviously to refer early if possible. So moving on to case 2 is that of a young 6-year, 5-month-old girl who had a slightly shorter history of puberty onset 1 month prior to being referred. She had no other features that would be consistent with puberty, just the breast development. And in her additional history, there again wasn't really that much that was quite significant to her presentation. Something interesting to note is the fact that the parents were both professionals, which may have precipitated an earlier self-referral, okay? And no pubertal problems within the family either. Physical examination, like the previous case, you can see that she's tall for her mid-parental height, but she's also quite heavy. So her BMI with a standard deviation score of plus 1.7 would indicate that she's actually overweight. She has no neurological findings on her physical examination, and she's actually in the earlier stages of puberty with breast development stage 2. So the growth chart again highlights, if you can see it clearly, that she's tall for her mid-parental height, and she is heavy as well, as I mentioned earlier. With regards to her investigations, her baseline biochemistry was normal, her bone age just slightly advanced, and this may be due to the fact that her puberty onset was quite of short duration prior to her presenting to us. And the LHRH stimulation test, which we use to prove the presence of biochemical puberty, shows that she has a stimulated LH level of 6.1. So anything above the level of 5 on an LHRH stimulation test would be consistent with an active hypothalamic pituitary gonadal axis. So what this shows us is that this young lady at the age of 6 years, 5 months old, indeed does have central precocious puberty. So she went on to have a pelvic ultrasound. Her ovaries are indeed pubertal volumes. And luckily, her MRI pituitary gland didn't show any sinister pathology. Her diagnosis is idiopathic central precocious puberty, and the treatment for these type of children would be to commence GnRH analog, which is leuprolide, which we give every 12 weeks. And she has remained on this therapy until today. She is nicely growing along the 50th centile and has a height velocity, which is in the prepubertal range of 5 to 6 centimeters per year. So what can we learn from this case? Well, central precocious puberty is defined as girls developing breast development, Tanner stage 2, prior to the age of 8. Now, unlike boys, idiopathic CPP is more common in girls, but the caveat is that girls less than 6 years old must get an MRI pituitary to determine whether or not there are any sinister central nervous system causes. GnRH analogs are effective in terms of height preservation, and they do allow for age-appropriate onset of menses. So the final case that I'm going to be talking about is that of a 9-year, 3-month-old girl who was actually referred to us from an outside hospital for menorrhagia. She had actually developed breast budding at the age of 8 years and 9 months, and she developed her periods at the age of 9 years. And the bleeding was quite heavy. She had anemia as a result of this, and she required a blood transfusion. There was nothing else untoward in her history. You note that she's small for gestational age with a birth weight of 2.45 kilos, and there's not much else in her family history. Physical examination showed that she was, again, tall, quite tall actually for her mid-parental height, and her BMI showed that she was quite obese as well. Now, unlike the previous girl, this girl was in a more advanced stage of puberty. So she was Tanner stage for breast stage 3 and pubic hair stage 3 as well, and nothing else much on her physical examination except for a little bit of acanthosis. Her investigation showed that she had normal baseline biochemistry. And in this girl, we decided to do basal hormones, such as LH, which is quite in the pubertal range, and a significantly elevated estradiol level. And you can see that her bone age is really quite advanced as well, as compared to her chronological age with a bone age of almost 13 years. And her pelvic ultrasound is also quite consistent with advanced stages of puberty. She went on to have an MRI pituitary, which showed that she had bilateral pituitary microadenomas. So what can we learn from this final case? Well, first of all, onset of menarche in girls less than 10 years old is not normal. This is deemed to be precocious puberty. And the aims of treatment are somewhat similar to other cases of precocious puberty. We have to determine the cause of the precocious puberty. We have to also consider the use of GnRH analogs where we feel that it is appropriate, and also to control the menorrhagia. So red flags in the road to referral. This is just a summary of my preceding few slides. So for girls less than the age of 8 years with breast development, or girls with menses prior to the age of 10 years, if they have a concurrent growth spurt during that time, it is advisable to refer early. Boys, on the other hand, if they have testicular enlargement prior to the age of 9, or testicular volume greater than 3 mils or greater than or equal to 4 milliliters, with associated visual field defects, or even without visual field defects or CNS signs, they should be referred to a pediatric endocrinologist as well. So these are my take-home messages, and it's my last slide. I think that these cases have highlighted, I hope at least, that it's important to know the normal stages of puberty in children if you are a physician that looks after children as well. Assess puberty for all children, whether they are ill or well. It's a good sign of their health. Educate your patients, and we have a lot of leaflets, as you can see here, about and their parents about what is normal puberty. Know the red flags and when to refer, and please do refer to us early. Thank you very much.
Right, excellent talk as always, Meenal. Thank you so much for that illustration. Yes, as has been highlighted by Meenal just now, our team has done quite extensive amount of effort to actually try and provide awareness to the public as well as our healthcare professional in terms about puberty in children. So the two books that we had, the Akil Balik for girls and also for boys, are actually a collaboration that we did together with the FMS group. Professor Amani now, Professor Aizura from ONG, Professor Hairinda from Ruka team as well, and Professor Yazid as well as our previous colleague, Dr. Ihsan. So if any of you are interested, please come and get it from us. We've got it in our clinic. It's good book to read for our children. Just to top up what Dr. Meenal has mentioned earlier on, is that where do we get all these cases from? So we do get the referrals from Paediatrician, but we have a lot of parents coming in, walk in to say, look, I'm a bit worried about my children. I think this is a little bit early. So we do take note that the awareness is already in, but it's probably not widespread. So we are seeing parents bringing in our children. Not to forget, we also have referral, like for the first case, Mina, if I'm not mistaken, it was actually detected by one of our neurosurgeons. Okay, the boy was actually referred to the neurosurgeons, and
Yes.
Obviously the neurosurgeons are actually the one who detected, oh my goodness, a 6-year-old boy with the voice of a 15-year-old. So that was a good pickup from our colleague. Thank you, Mina. So shall we move on to Dr. Shadia? So Shadia, can you please switch on your video now? Shadia is our a trainee, actually a SLAP trainee, right from 2008, since she came back from Manchester after her working experience back in UK. So Shadia has actually been with us for quite some time now. She just recently passed her final exam in pediatric endocrinology fellowship training in Malaysia. And she has had her an attachment in Singapore. So now she's one of our team member as pediatric endocrinologist here in UMMC. So Shadia, please enlighten us about precocious puberty in children.
Thank you very much for the kind introduction, Prof. Yanti, and also thank you to Dr. Meenal for the interesting cases presentation. So I'll continue with the current trend in central precocious puberty. Before that, I would like to apologize if the talk might be interrupted with my some hoarse voice and also a bit of coughing. Well, okay, we'll move on. Okay, my talk will be on what is puberty, what is precocious puberty, and why is it important to recognize precocious puberty, what are the types of precocious puberty, and the current trends of central precocious puberty. Well, as we know, puberty is an important phase of physical transition from a childhood into adult phenotype with the ability to reproduce. And puberty has a variation in terms of the onset, timing, and also tempo. For girls, it can start as early as 8 years old, up to as late as 13 years old. And for boys, as early as 9 to as latest as 14 years old. So puberty that happens outside of this timing will be considered either too early or too late. So what are the factors that govern the timing and also the tempo of puberty? This would include genetics, familial, and nutrition, and also environment. Well, what about precocious puberty? As Dr. Meenal has mentioned, he has already demonstrated 3 cases. So we know that early development of secondary sexual characteristics before 8 years old in girls and 9 years old in boys is deemed to be precocious. However, it is more common in girls, up to 5 to 10 folds as compared to boys. And what are the risk factors? Risk factors include baby who are born small for gestation age, those children with previous brain pathology, such as babies who were born with hypoxic ischemic encephalopathy, or those with congenital pathological brain malformation, such as congenital hydrocephalus, and also children with obesity. So why is it important to know this? This because young children who has precocious puberty, they will have discordant of the physical features and also their age. So imagine a young girl of 5 or 6 years old with a breast development, or young boy of about maybe 8 or 9 years old with voice changes. So it might appear awkward, and they might also feel awkward themselves because they are different from their peers. And the other thing that is important, because as we know, puberty, during puberty, there's a height spurt. So if puberty occurs earlier, the height spurt occurs earlier, and the growth plate closes earlier. So with treatment, we are able to preserve their adult height. And also psychological impact, especially when their mental capacity is not concordant with the physical features, and also especially for girls, they might have early menses. So at early age, they might not be able to cope with problems associated with menses, such as dysmenorrhea or menorrhagia. Okay, this is a chart showing pubertal change timing in UK adolescents back in 1990. So that's quite a long time ago. But this is only the only chart that I can find in the literature. So we can see that the height velocity for girls happens between 11.5 to about 13, and for boys between 13 to 14.5. So if there is precocious puberty, this peak height velocity might shift earlier, and they might look tall and at the current age, but actually that can compromise their adult height, because the bone age will close, the growth plate will close earlier. So they might end up shorter than their peers who are still growing at later age. Okay, move on to what are the other types of precocious puberty. So central precocious puberty, as mentioned by Dr. Meenal, this is the gonadotropin dependent, whereby it is dependent on the luteinizing hormone and follicular stimulating hormone from the pituitary. And as mentioned earlier, in girls it's more common. However, in boys, you must be aware that most of the cases are pathological. So with CPP, it is associated with growth spurt, advanced bone age, and also increase in baseline LH, and also pubertal response to GnRH. Peripheral precocious puberty otherwise is not dependent to the gonadotropin, which are the pituitary. So it is due to endogenous or exogenous causes that causes the sex hormone to be elevated. And this can also be found in certain syndromes. And premature telaki is the most common one. Self-limiting isolated breast development, which is not associated with growth spurt or bone age advancement. And it is seen commonly in mini puberty for those babies who are just born up to 1 year old, and preschooler or young girls aged 5 to 8 years old. And the last one is premature adrenarche or probarche, where there is an isolated development of pubic or axillary hair. However, this is a diagnosis of exclusion after we have ruled out other sinister causes, such as virilizing adrenal tumor or congenital adrenal hyperplasia. Well, what's the current trend? We are observing the age of onset of puberty, especially in girls, is becoming younger since the past 30 to 40 years. Can this be due to better nutrition, increasing obesity incidence, and also presence of endocrine disruptors? And or maybe because of more awareness and we are getting more referrals for assessments. So I would like to share a few papers, and this is the first paper, which is a systematic review on the onset of telaki. It is a meta-analysis of 30 articles which were published between 1977 to 2015, looking at sample sizes from 138 to 20,000 plus healthy girls. And they found during this a span of years, almost 30 years, more than 30 years, the telaki, which is breast development B2, has decreased, meaning becoming earlier by 3 months every 10 years from 1977 to 2013. And they found that median ages of development of tender breast 2 is younger in Asia and also United States, especially in African American girls. So this is the scatter plot showing the median or average years where the telaki started. So we can see from 1977, it's around above 10 years old. And for Africa, the median age is even later, maybe because of the undernutrition. And as it progressed, you can see that in Asia, it has reduced to less than 9 years old, and also same with North America. Other study in Denmark looking at about 20 years, the span of 20 years, and looking at all types of puberty. And we can see that's a steady increase and a steep increase between 2006 to 2008 in terms of the incidence of all types of puberty, either central precocious puberty, premature adrenarche, or premature telaki. How about in Korea, in Asia? They're also witnessing the same trend, whereby for girls, there's about more than four folds in a span of 6 years, and for boys, almost 10-fold from the baseline. Although girls is look a bit steeper, actually for boys, the increment is actually higher. And according to the age, of course, we are expecting a borderline age between 7 to 8 and also 8 to 9 years old. Okay, how about in China? So this is a study in 2009 looking at the median age of the development of breast, stage 2, occurring earlier at 9, barely above 9 years old, and menarche just barely above 12 years old. And the trend from 1979 to about 2005, they are witnessing decrement of age of menarche about more than 1 year, from 13.5 years to 12 years 3 months. So with earlier telaki, and we are expecting earlier menarche as well. Okay, there's a debate of precocious puberty and also obesity. I'm just sharing 2 papers which are looking at incidence of precocious puberty in obese children as compared to the normal weight. And this the first paper is looking at this is a Chinese a study in China looking at the preschool children, and they found that those obese children has higher percentage of precocious puberty as opposed to normal weight or teen children. And in boys, it was also found that obese children has younger age of development of testicular volume of above 3, as opposed to boys who with normal BMI. And for 10% of these boys had testicular development above 3 before 9, which is CPP. They are found to have higher birth weight, higher obesity rate at 2 years old and subsequent visits. So what about in our center? We are also witnessing more and more CPP precocious puberty being referred to us and more being diagnosed. As you can see, it peaks at 2019 to 2021. And as for 2022 this year, we have already have 7, and this is only until mid-February. So if this trend continues, we are expecting about maybe around 30 to 40 cases this year. just a short one. The final height in our treated patients, we only had 9 patients who we managed to get the final height. We found that their final height, the mean final height, is slightly below the mid-parental height, about 2 cm. We have to also consider, we didn't look into detail, like what is the stage of puberty, whether they presented late. If they presented late, then the height preservation might be compromised as well. Okay, my last slide. Why should we address CPP? This has been a neglected area in the past because the perception is that these conditions were rare, but they're not. Nothing could be done, as people might say, this is a natural, puberty is a natural phenomena for growth, but if it's occurring earlier, it is not normal, and there's something to be done whereby we can offer treatment. And people might think that treatment is risky and dangerous. Yes, the treatment is in terms of injection, but almost all of our patients tolerate the treatment very well, and we have not seen adverse effects as well. So treatment is not available to help timely puberty and optimize outcomes, especially in terms of the secondary sexual characteristics, and to get the children to attain their optimal genetic height potential. And as shared earlier by Dr. Meenal, these are the resources for our patients so that they can understand what is happening to their body better, and also the treatment that we offer. Thank you very much.
Thank you so much, Dr. Shadia. Excellent brief on the whole perception and understanding about CPP. In view of time, I know that we don't have enough time to discuss verbal or discuss virtually the Q&A that has been addressed in the Q&A box. I thank all for asking us a lot of questions. We have started to answer them through the Q&A box. I believe there are also more concerns and questions in regards to the treatment. And if you are keen to know a little bit more, please do email us. I will put in our email address in the chat box in a while. And then you can get the more information and the info leaflet, at least one I have already shared in the chat box from our team. So I would like to hand over the next session to Dr. Fajlina. Go ahead.
Hi, very good morning and Assalamualaikum. It's my pleasure to introduce the next two speakers. We have here Dr. Beh Hooi Chin. She's a family physician who has a special interest in managing older patients in primary care, from prevention, acute, chronic, and end-of-life care. So today she'll be sharing a case whereby from the primary care perspective, managing an end-stage renal failure patient. And she'll be pairing today with our one of our consultant physician in palliative care, Dr. Sheriza Izwa Zainuddin, who has special interest in palliative nephrology. She also has started a renal palliative clinic in UMMC. So I think this two great specialist input will help us to understand this topic, which is to dialyze or not, how far do we go? So I pass the session to Dr. Beh and Dr. Sheriza.
Okay, good morning, everyone. Thank you, Dr. Fazila, for your kind introduction. So I myself and Dr. Sheriza will be sharing with all of you of one of my patients that I've seen in Luka, to dialyze or not, and how far do we go. So it's always good to start a presentation with a patient, with a case scenario. So this is a patient of mine. This is a photo that I took from Google. It's not my real patient. And she's Madam M, 81 years old, Malay female. She has underlying type 2 diabetes, hypertension, stage 4 CKD. She came for routine follow-up with her daughter during this visit. However, she did not have any acute complaints during this visit, and she's still able to pass quite a good amount of urine with no frank hematuria, no bleeding tendency as well. She did not complain of any chest pain or bone pain. So further discussion, we realized that the patient not keen for renal replacement therapy, particularly with hemodialysis, as she was worried of the complication of the hemodialysis. And this was because from her experience in taking care of her late husband, who also been through in hemodialysis. And her reason that she refused and not keen for renal replacement therapy was because that her husband's sugar was very bad control that time, which needing to start on insulin. So she actually related due to the hemodialysis itself, which we think that it's actually is quite a common misconception for our patient. So otherwise, she also not keen to be referred to nephrologist because of she's not keen for the dialysis. So her diet history-wise was quite okay, and she was a housewife with 6 children. She has low educational level. These are the long list of her medications. She adhered to her medication, and all the medication was given by her daughter. So on physical examination, she has a mild pallor. We can see from here that her blood pressure is on the higher side with a normal pulse rate and also normal BMI. However, her home blood pressure was quite a good target for her age. Is quite acceptable. And for the investigation, you can see from here, her urea creatinine and also eGFR has been quite static throughout few visits in Ruka, and she was anemic with a HP of 8.7, and it was a normal chromic, normal cytic. And we can see that her HbA1c, her sugar control, and fasting lipid was quite good control. But we might need to interpret the HbA1c carefully because patient is anemic, so it might give us a false, inaccurate result. Her urine PCR was high, and her serum iron was borderline low with a normal TSAT, transferrin saturation. So now the question is to dialyze or not for Madam N for this patient. So we would like to correct her misconception that actually was the poorly controlled sugar and needing insulin was not due to hemodialysis. However, she has a quite fixed idea since a long time ago that she's still not keen for dialysis. But although that she was not keen for dialysis, we still need to control the other risk factors such as her blood pressure control, her sugar control as well. I do advise her to avoid nephrotoxic drugs and also some traditional medication or some supplements. And at the same time, to manage the complications. I discussed with her and the daughter whether the need of initiating of iron treatment. She already on a ferrous number of 400 BD, which is a high dose. However, her HB was still not optimized, so there might be a needing of either erythropoietin or IV cosmopher for her. At the same time, we also refer her to dietitian. So now, further discussion, she actually mentioned that she's keen to discuss with the son who is the decision maker. So wait, and who is the decision maker here and how should we proceed? So on further discussion and further history, I found that Madam N had actually memory impairment a few years ago, which was worsened for the past 1 year. She was still quite independent in carrying out her daily activities and her chores, but she has lost her instrumental activities of daily living, such as like using phones, calculating monies, handling monies, and also shoppings. So she actually lost all these functions in her daily practice. At the point of assessment, she did not have any BPSD, the behavioral and psychological symptoms of dementia. She did not have that time. And there was no focal neurological symptoms and no significant family history as well. So proceed with the cognitive assessment. We do have this validated Malay version of MMSE, which was actually also one of the reference in our CPG in dementia, management of dementia. And she scored only 10/30, which I diagnosed her to have dementia during this visit. So I actually called up the son to make an appointment to have a small family conference to discuss on how do we going to manage Madam N and who will be going to be a decision maker and going to be decide on what are we going to proceed in managing this patient. So how would we manage this group of patients in primary care since that she's still not keen for dialysis? So actually, I've seen quite a few number of similar patients in our clinic. So as a primary care physician, the decision to initiate dialysis is best made through shared decision making. and as well as to focus on the patient-centeredness. And do not forget about comprehensive memory and functional assessment. And also, it's important for us to advise on safety for the patient and advise on falls prevention as well. So when the patient presents with a memory impairment, we need to screen for depression and also BPSD, the behavioral and psychological symptoms of dementia, is very important, as we can start treatment for this group of patients. And don't forget to also manage the other comorbidities, like for my patient, we do need to make sure that the blood pressure and sugar is well controlled, and also necessarily to review the medication. Appropriate de-prescribing is important in this group of patients. So prevent and also treat complications associated with end-stage renal disease, such as like anemia, renal bone disease is also important. And to prevent malnutrition, and also try to restrict the sodium and potassium in her diet as well. Of course, prevention is always better than cure. Providing vaccination for this group of patients is also important. So last but not least, appropriate referral to nephrologist and also palliative team, especially on discussion of advanced care planning, is important in this group of patients, which will be further elaborated by Dr. Sheriza later. So just a quick cap on the prevalence in our country. We can see from here that number of new dialysis patients is increasing trend from 2007 to 2016, with highest number are patients more than 65 years old and above. And some studies describe that renal replacement therapy requires lifestyle modification, which often creating dependency on others. And of course, we know that diet restriction and also strict adherence to the dialysis schedules and also financial stress is also one of the difficulties for certain patients. So some patients, they might struggle with the decision of whether to commence dialysis or to live with a significant symptoms burden. So this table shows that what are the common symptoms that we can see in advanced renal disease. So you can see from the first few row here, like lethargy, pruritus, feeling drowsiness, shortness of breath, are quite common symptoms that we can find in this group of patients. But fortunately, Madam M, my patient, at the moment, she did not complain of all these problems. Yeah. So these are just a continuous table. So it's also can see from this chart, more than 74 years old, population more than 74 years old have the lowest rate, survival rate if they are going for dialysis compared to the younger group of patients, which they are having a better survival rate compared to those young, older patients. So that's why it's important for us to evaluate whether the possible initiation of dialysis in geriatric patients should be commenced or not. And it should be always in the multidisciplinary approach. So if let's say the RRT is not pursued, optimization of medical treatment and also symptoms relief needs to be the goal of care. So as we mentioned above that patient-centeredness is important, and also is an important principle of family medicine, that we usually need to focus on the patient and the individual's particular health and care needs. It also empowers patients to become active participants in their care. So with a good patient-centered care in our management, it actually provides better patient satisfaction, and also patient will be adhere more to the treatment that we provide to the patients. And in overall, it will improve the quality of care for the patient as well. And these are the components for patient-centered care includes of course, the first one will be the patient's preferences and their values in their life. And we do need to provide information and education to the patient. Coordinate care with, like for Madam M, for this patient, I tried, although she was not keen to be referred to a nephrologist, but time to time during the management, I've been calling and also discussing how are we going to manage this group, this patient with a nephrologist, geriatrician, as well as palliative team. So important to provide emotional support for patient and also for carer, and physical comfort for patient. We do involve family and friends, mainly family for Madam M, that we have this family conference with the son and also the daughter. to how to proceed with the management for her. Yeah, so shared decision making is always come hands in hands with patient-centeredness in primary care. So it's a combining perspective between both clinicians and patients, where a clinician, we will provide expert guidance, our clinical evidences and therapeutic goals, while patient, they will share what is their preferences and lifestyle and values in their life. And they also will share what is their treatment preferences and their personal goals. So both of these will come to a shared decision making in order to achieve optimal patient care. Sorry, it's quite a busy slide, but it's just to describe a study that they describe the decision making in helping geriatric patients especially for end-stage renal patients. So it's a multidisciplinary approach from nephrology, geriatric, and of course from palliative care and primary care as well. So subsequent visits for Madam N, she was asymptomatic. There was no bleeding tendency. Her blood pressure is still on the highish side. And you can see from here that her HP was dropped 1 gram. And her urea creatinine also had worsening, with eGFR is only 12 now. And this brought her to the subsequent visits and also the first admission to the ward with hypertensive emergency with acute pulmonary edema, mainly secondary to the disease progression. So her Bartter index scores was quite good initially, premorbidly. Bartter index is a score to assess a functional dependence, whether how dependent the patient to the carer. Usually we can use it on the patient, elderly patient, or geriatric patient or a stroke patient. So during this visit, a patient, Madam M, developed PPSD, where she became agitated and quite difficult to manage. That's why the daughter had carer stress. And this is also important for us to identify and treat the carer as well. And also, so for during this visit, I discussed about advanced care planning with the family, and also referred and also coordinate care with the geriatric and palliative team. So which I think Dr. Sheriza will describe more and also elaborate more on how do we manage this group of patients as in terms of renal palliative and also advanced care planning. So I think Dr. Fazila had already introduced Dr. Sheriza. She's a head of unit of palliative care in UMMC. So I think without further ado, I'll pass the Zoom platform to Dr. Sheriza. Yeah, thank you, Dr. Sheriza.
Hi, good morning. Assalamualaikum and good morning. Thank you, Dr. Beh, for the presentation. So yes, here I am here to advocate and also enhance our knowledge regarding renal palliative with the and also advanced care plan, which has been fully used in the patient that Dr. Beh have shared with in the case study. So here, what I'm going to do is to introduce renal palliative. We talk about the objective and also what is actually the conservative care. And then what is the model that I'm using in the UMMC since I started this renal palliative clinic in collaboration with the nephrology team in PPUM. So before that, I'll just give you all an introduction regarding what is the role of palliative care in end-stage renal disease, because I think this is still not well known to majority of us. Only those who have contact with patients requiring palliative care in end organ damage would be aware of what are the role that we are giving of providing. So as we all are aware, like Dr. Beh have said, the characteristic of patients who require dialysis have changed over the years. More elderly patients with more comorbidities and more elderly, more than 75 years old. So at the same time, we also are aware that patients with end-stage renal disease with or without renal replacement therapy would have reduced life expectancy as compared to our other age match controls. And these patients with end-stage renal disease have a lot of symptom burden related to the disease of end-stage renal disease and also other comorbidities. So I'm here showing some study from Muntaj regarding dialysis or not, looking at how symptomatic these patients are. And what is the survival. Of course, with this study, they shows that when a person is started on dialysis, the survival rate improves significantly. However, this survival benefit would be lost if one of the comorbidities suffered by this patient is IHT. So if you see, the survival would be similar with dialysis and non-conservative group. So here we know that in summary from this study, it shows that comorbidity should be a major consideration when advising elderly patients for or against dialysis. So I would like now to show what are the guidelines that we use to say that conservative management is an acceptable option for CKD patients approaching end-stage renal disease. So this carrying for Australian with renal impairment guideline, counseled by the Australian and New Zealand Society of Nephrology, said that a useful point of recommending dialysis is an exception of survival with a quality of life acceptable to the patient. So this is in the ethical consideration, and in this ethical consideration also, they recognize conservative management as a treatment option for patients with end-stage renal disease. And another guideline by the Renal Physician Association in US 2010, in their recommendation number 6, they said that it is reasonable to consider foregoing dialysis for patients who have end-stage renal disease patients who have poor prognosis or for whom dialysis cannot be provided safely. So what I'm just introducing with this slide is that conservative management for dialysis is appropriate, is acceptable for the right cohort of patients. Okay, so what is the renal management of end-stage renal disease? It can be decided in consultation with nephrology or the treating physician, as in Dr. Beh's case, the patient is under the primary care, primary medicine care. They are looking at the patient holistically and have made the decision regarding renal palliative, and patient have decided on conservative. So, or the patient may have decided on conservative management for some certain reason that is appropriate, or the patient is unable to be doing dialysis due to access or even affordability. However, affordability currently, we have all the other resources to assist patient for dialysis. So when should renal or conservative care be started or initiated? Ideally, it should be started early at stage 3A, 3B. Why? I will tell you in my next few slides. It can also be initiated pre-dialysis as per patient's request, or during dialysis when there may be new issues or maybe new comorbidities that may lead to patients being not safe for dialysis, or when patient requests for withdrawal from dialysis for maybe futility of care, or again being unsafe, or dialysis cannot be provided safely. Okay, so what is the objective of end-stage renal disease conservative palliative care? Our main aim is to preserve whatever residual renal function that is left in the patient maximally, with, of course, BP control, sugar control, fluid control, electrolyte control. And of course, with this patient, we know they may have a lot of symptoms. Symptom control is, of course, what we also look into. We also do psychosocial and spiritual care, looking at what are the expectations, what are their distress, concern. We support patient and their family with this decision. And of course, one thing here we discuss is about the advanced care plan and end of life. What are expected symptoms that they may experience, what are the changes that they may experience, and if this occurs and when the patient is incapable to make their own decision, what will happen. So all these are already in written, so it is easy for the physician in charge to guide their management. Also, so what is the model that I use? Here is the similar model of collaboration between palliative care and renal team, as what we see in collaboration model among gynecologists, oncologists, even the surgeons, with also the oncology. So this is the model that I use. So what has happened in UMMC is we have started the renal palliative clinic since March 2018. It is situated in the Wednesday Renal Clinic, whereby there is one fixed room for myself in the renal clinic for all conservative patients requiring palliative input for conservative care. So far, as of currently, we have around 164 patients already in the renal palliative census. Of course, with these past 3 years, there would be already patients who died with this renal palliative, which is expected. And this is a collaboration with UMMC nephrology team with Prof. Lim Sukun and team. So what happens also, we have frequent ward reviews in the nephrology ward or in any other medical ward, MDT, together to discuss about the goals of care of this patient, what are the expectations from family members, distress from the patient with the decision, or what maybe they can have pollution whereby patient wants conservative, however family feels, oh, we have to go for active dialysis. So where is the how do we bring this together for the whatever advocate for patients requests or patients wishes. And of course, the PCU, primary palliative care unit, we support renal palliative patients for admissions when they need symptom control or even some requests for end of life in the ward. So in the renal clinic, we have regular follow-up, focusing on symptom management. Of course, at the same time, while doing symptom management, we do also talk about advanced care plan, what are the expectations. We talk about psychosocial support, patient and family. And as mentioned, admission to PCU for symptom control, end of life, and even respite. So here, just remember, a palliative approach can play an important role throughout the course of the end-stage renal disease. The challenge of renal palliative is to make sure that this pathway is not seen as second best or inadequate. However, it has to be thorough, systematic, and evidence-based. It's not about abandonment. That's why we are sitting in the renal clinic, so that at any point, if the patient feels that they need to see a nephrology to actually discuss regarding their decision, again, the nephrologists are just next door. We can always bring in the nephrology to again sit down, have an MDT, easier discussion. So it's not an abandonment. It is more of a teamwork, making sure that there is holistic care for the patient. And for renal palliative, it's not simply transfer to palliative care. So now, just quickly about advanced care plan. So advanced care plan is an ongoing process of communication between patient, family, loved one, segregate decision maker, and healthcare provider regarding prognosticate information, therapeutic option, what the patient wants, the wishes for further treatment, and also to honor the patient's preference. So ACP allows individuals to plan for future healthcare. In any event that they are unable to make any decision, ACP can be conducted in a healthy individual or anyone who is being diagnosed with cancer or even an organ damage, or even, like I said, any healthy individual. Just to show you the availability of ACP, we in Malaysia do not have any national ACP program at this point. However, there have been regional initiatives. I hope there will be a national ACP program in Malaysia soon. However, you see, even in our neighboring countries, Singapore, Taiwan, there is already a national program on ACP. So the purpose of ACP is to offer people opportunity to plan for their future care and support, including their medical treatment, when they have the capability to do so. So as Dr. Beh's case, she had decline in mental capacity. So if we have discussed ACP beginning, we would already be aware of her preferences, what are her choices, so that the segregate decision maker or even proxy be able to guide their decision according to her preference. So, like I said, why does it matter ACP? It facilitates the selection of optimal medical and non-medical care by the patient when they can retain their capacity, mental capacity, and this decision making can be used when they cannot retain their mental capacity. We have to also acknowledge that ACP does not increase or result in distress with the patient or even the segregate decision maker when they are talking about decision making. Okay, so who are involved? The patient, his or her segregate decision maker, family members, of course, and involved clinician. The components of ACP, we have to understand, reflect, and discuss patient's individual health status. So that means the patient must be aware, you must discuss about disease trajectory with this patient, what are the expected symptoms, what are the expected treatment, and what are the outcomes, so that we can actually know what are their goals and values and preferences. With that, we can then formulate and document a plan. And when we have this plan, we have to communicate this plan with their patients, the patient's next of kin or loved one, and of course the medical team. So some will say, if this patient have several doctors are maybe in primary care, nephrology, diabetic doctors, so how? So I would say maybe one doctor to be the moderator among all the other doctors, so that the plan is known to everyone treating the patient. And if the patient have this, they should document and always bring this document to the follow-up and show it to the treating doctor. So at least everybody will have an idea of what their preference are, their values and goals. And of course, this ACP is not a one-off discussion. It has to be reviewed periodically and of course remain whatever the patient's goals and values are. Why we have to discuss periodically? Because health changes, our health condition changes every time. We can improve or we can decline. So we have to make sure that this plan is up to date, and making sure at the end of the day, the plan is planned out accordingly to the circumstances that is planned. So in summary, understand the disease, what the patient have to understand the disease process, what is the expected symptoms. You have to understand, we as doctor also have to understand what the patient's expectations are, what are the goals are, values, so that we can guide the patient accordingly. So when to start, it should take place in the outpatient setting. Why? Because in the outpatient setting, ideally patients are usually in a health stability. If you can do it inpatient, however, sometimes patients come in acutely for infection, or maybe they may be too lethargic to take part in this ACP discussion. And of course, it should be initiated by physician, however, not forced on. Okay, so the take-home message for renal palliative, it is an acceptable option for appropriate patients with CKD approaching end-stage renal failure, and the care should be started early. ACP, even though it's not a national program yet in Malaysia, we should advocate for ACP, start initiating the discussion, and of course documenting it. Thank you, everyone. I know I passed a bit of time and I'm a bit rushing because of time. However, I hope all of you are enlightened with the topic. Thank you.
Yeah, I would like to thank both the speakers. I think this gives us an idea on what is happening in primary care and towards the end of the patient care in palliative care. As you know, it's easier said to be done. Prevention is better than cure. But I think with our Malaysian demographic, which is changing to an aging nation, perhaps in less than 10 years, we'll be seeing more older people living longer with a chronic disease. This is because there are two reasons. Because they have Malaysia has low birth rate and we have a better healthcare services. So there might be more older people outside there. They don't have any close relation to make decision when they have any mental incapacity. Hence, I think we should start discussing about ACP with all our patients, especially as suggested by Dr. Sheriza. I think outpatient, when they are still well, is the best time for us to start talking about ACP. But I still feel that talking about death and dying in Asian people is not is as easy, so anyhow we have to start doing that with our patient and to see how our patient acceptance for ACPs. I would like to thank both the speakers. I think Dr. Beh have answered some of the question in Q&A slot. I think there's one question for Dr. Sheriza. Perhaps Dr. Sheriza would like to answer it online, or you want to answer? You want to type it up?
I will type it. Thank you. Yes.
Okay, so Dr. Sheriza will type the answer. If there's no more question, I think we should end this session so that we can go back and continue with our routine. Thank you very much for all the speakers.